Dr. Zohaib, if you're ready, I'm just going to do a brief introduction and then you can start. So I'm sorry for the delay. I welcome you all to yet another session of the Residence Corner module. Please mute yourself, Dr. Zohaib.
Sir, can you hear me now?
I can hear you. I'm just doing a brief introduction and then you can start. Mute yourself till that time. So these sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital. The idea behind this session is to build 3D neuroanatomy, which is very eminent and important for neurosurgeons while performing any neurosurgery. The topic of our presentation today is Orbit. It is a continuation of the last week's presentation. So Dr. Zohaib, who's a Air 1 resident, will start with a brief review and then we'll continue. With today's topic, it gives me extreme pleasure to announce our expert panelist today. Dr. Hasan Syed is consultant neurosurgeon with special interest in pediatric neurosurgery and is working at University of Virginia. Dr. Syed completed his internship and residency at Georgetown, where he received multiple awards, including the AANS Traveling Fellowship Award. He also has masters in biomedical engineering and has been putting scholars for research regarding stem cell. Dr. Hasan Syed, it's a pleasure to have you.
Thank you very much. I'm very excited to join and looking forward to the presentation.
Thank you.
Okay,
Dr.
sir.
Zohaib, can you start?
Yes, sir. Yes, sir. Sorry for the delay. So today's topic is for neuroanatomical case discussion is Orbit. Just a recap of what we discussed last week. So introduction, the Orbit is a complexly organized group of neurovascular, muscular, ligamentous, and osseous structures that open onto the face and external world to collect and provide binocular visual information to the brain. The globe is surrounded by precisely coordinated group of muscles encased in a fat to allow free movement of globe muscles, but limited at the extreme by ligamental structures to prevent excessive mobility. Nearly all bones forming the anterior and middle cranial base contribute to the formation of Orbit's wall. So here's the diagram. Basically, Orbit is mainly formed by 7 bones, namely frontal, zygomatic, maxillary, lacrimal, palatine, ethmoid, palatine, and sphenoid bones. So here it is showing the is a superior orbital fissure, inferior orbital fissure lying in the greater and smaller, lesser wing, while the optic canal. And here is the fossa for lacrimal sac. So here's the infraorbital notch, infraorbital groove basically, and and supraorbital notch. Moving on to, so this is the magnified view of the foramen. So this is the optic canal separated from the superior orbital fissure by optic strut, part of lesser wing of sphenoid. Here is the ethmoidal canal, while posterior ethmoidal canal located here. And this is the frontal aspect. This is the basically anterior view, but magnified. So this is the roof of Orbit viewed from below. Here it is showing the ethmoidal air cells, cribriform plate, lacrimal fossa for the lacrimal gland, trochlear depression for trochlear attachment, supraorbital foramen. This is basically viewing the orbital roof from below. Supraorbital foramen as shown in frontal bone here and here, while this is the greater wing and lesser wing and superior orbital fissure margin. So here is the metasplenial fossa. Moving on to, so this is the roof viewing from superior and like from the anterior cranial base. So here it is the frontal sinus, frontal bone, ethmoidal bone, crista glyph basically gives the attachment for the false cerebri, while cribriform plate shown here, which gives the attachment to olfactory bulb, where olfactory bulb lies. So here's the lesser wing, greater wing, and anterior clinoid process. Here is the foramen ovale, carotid canal, and tuberculum sella, basically connection middle cranial fossa. So this is the base of orbit as viewed from above. You can see the anterior is connected to lateral wall, but at the posterior aspect, it is separated from the lateral by inferior orbital fissure. Here's the infraorbital groove. Here's the nasolacrimal canal, zygomatic arch. Here's the optic canal and palatine bone. Here's the foramen ovale, as you can see, and here's the ethmoidal ear cells. Okay, so here's the roof is being basically base is removed of orbit, which was usually formed by the orbital plate of maxilla, orbital plate palatine bone, and orbital plate. It is being removed. Underlying it is the maxillary sinus, nasolacrimal canal, pterygopalatine fossa, palatine bone, and greater wing of sphenite, infraorbital fissure. And here's the zygoma. Here you can see the nasolacrimal canal. Here is the later view of orbit, where from the anterior aspect, where you can visualize the zygomatico-orbital foramens, zygomatico-facial foramen, lacrimal fossa, superior orbital foramen, lacrimal foramen, sorry, and superior orbital fissure. Moving ahead, orbital structure. So this is viewed from superior angle. After removing the dura, you can visualize the frontal bone, olfactory bulb, lesser wing of sphenite, optic canal, and anterior clinoid process. When removing the frontal bone, sphenoid bone, you can visualize, and the periorbital fissure reflected, you can visualize the frontal nerve going ahead, while the lacrimal nerve traveling laterally to the lacrimal gland, cranial fork, trochlear nerve, while the cranial nerve viewed below, underneath it, carotid artery. Here is the optic sheet and optic strut, separating optic canal from superior orbital. So after removing the orbital fat, you can basically visualize the ophthalmic artery nerve, which divides into frontal, nasociliary, and lacrimal nerve. Frontal nerve dividing into nasociliary, ophthalmic dividing into nasociliary nerve, frontal nerve, lacrimal nerve. Nasociliary travels ahead, further giving divisions to superior trochlear nerve. Here is the trochlear attach, while the trochlear nerve is traveling to the superior orbital oblique muscle. And here is the carotid artery. Here you can visualize the superior ophthalmic vein. And here is the superior rectus muscle, lateral rectus muscle as shown here. Lacrimal gland lying laterally, which is supplied by the lacrimal nerve. After basically removing the frontal nerve, levator muscle, and superior recti divided, it is exposing the superior ophthalmic vein, ophthalmic artery, and nasociliary nerve. As shown here, nasociliary nerve, superior ophthalmic vein, reflected. Here is the superior division of cranial nerve 3, oculomotor nerve. Here is the the dura is being removed from the Gazerian or Meckel's cave, showing the trigeminal division, ophthalmic, maxillary mandibular. Here is the trochlear nerve. Here is the oculomotor nerve. Here is the superior division of oculomotor nerve. Further dissection will reveal out the inferior division. So here is the further dissection, which shows the inferior division. Inferior division is divided further into 3 branches, which are the medial branches, medial margin. Second is supplying to the medial rectus superior surface of the third rectus, and third branch to inferior oblique muscle, which also gives supply to the parasympathetic root of ciliary ganglion, as shown here. Ciliary ganglion, motor root. Here's the frontal nerve, sensory roots. Here's the inferior division of oculomotor nerve and superior division. Here's the cavernous sinus medial to the trigeminal ganglion, cranial nerve tree. Here you can visualize the trigeminal division, giving the ophthalmic, maxillary, and mandibular division. Here is the cavernous sinus, as shown here, basically medial to the trigeminal ganglion. Trigeminal ganglion, also known as Gazerian ganglion. So here is the basically also called Meckel's cave. Here's the cranial nerve tree. Here's the basilar artery, as shown, carotid artery, and here's the cranial nerve to optic nerve. So here's the lateral left lateral view. Here you can visualize the V1 aspect, V2 aspect of branches of trigeminal ganglion, optic strut separating the superior orbital fissure and optic canal. Here you can visualize the optic nerve, carotid optomotor nerve, and trochlear nerve. Here you can visualize this superior ophthalmic vein, as shown here. Okay, so here is the annular ligament, basically foramen, in which basically travels the annular tendon, superior cranial nerve, 3 superior division, necessarily traveling within a clonoid segment, and trochlear nerve. Here's the superior division of cranial nerve 3 and inferior division traveling in oculomotor foramen, while the cranial nerve 6 abducens nerve also travels within it. Here's the lacrimal nerve, and here's the frontal nerve. So after removing the annular tendon, division between origin of superior and lateral muscles, rectus muscle, abducens nerves enter the so here's the cranial nerve 3 inferior division, while superior division ophthalmic artery and nasociliary nerve. Here's the lateral rectus muscle visualized. Here's the V1 division of trigeminal nerve. Here's the cranial nerve 4 and trochlear nerve. So So here is the basically supply of the muscle to the skin. Here the orbital part of orbicularis oculi muscle removed while preserving the palpebral part. Here is the orbitus oculi muscles, palpebral part, while the supraorbital nerve leaving the supraorbital groove and infraorbital nerve through different movement. So here is the anterior view of cross section of deeper vessels at the anterior aspect of coronal section or at right orbit. Here you can visualize the cranial to optic nerve, while medial to is the ophthalmic artery, nasociliary nerve, optic sheath. Here is the medial rectus muscle, inferior rectus muscle, and here is the inferior ophthalmic vein. Here you can visualize the lateral rectus muscle, while the cranial nerve 6, abducens nerve, laterally lying. So here is the anterior aspect for the division, where the orbital fat has been removed and lateral rectus has been reflected to expose the ciliary ganglion, as shown here. The ciliary ganglion, and there's it's short ciliary nerve, while the motor root and sensory root, while cranial nerve 6 traveling ahead of above the lateral rectus muscle. Here's the ophthalmic artery and superior ophthalmic vein. Arterial relationships. So here's the superior view of orbit of right orbit, basically showing the ophthalmic artery traveling above the cranial nerve 2, as shown here, which further, as it progresses in its course, gives anterior ethmoidal and posterior ethmoidal artery in between the superior oblique muscle and medial rectus muscle. Here is the cranial nerve 3 and medial rectus muscle. Here is the ophthalmic artery, which is given underneath the cranial nerve 2, and here is the ciliary artery. So here's the segment. Here the segment of optic artery is being removed, showing the central retinal vein, which is underneath the cranial nerve 2 optic nerve, and here is the ciliary nerve. Here's the ophthalmic artery, which segment is removed. Here's the inferior surface showing the tortuous course of central retinal artery before it pierces into the lower surface of optic nerve. At the medial end is located medial rectus muscle. Here is the ciliary artery, while cranial nerve 3 to medial rectus muscle. And here is the cranial nerve 2 to oblique muscle. Venous relationships. The venous spaces of cavernous sinuses fill the posterior margin of superior orbital fissure and may extend forward along the medial and lower edges of fissure. And may extend forward along, the veins passing through the fissure empty into the cavernous sinus. The superior ophthalmic vein arises from tributaries in the superior medial aspect, as shown in the previous diagrams, and superior medial part of the orbit, and inferior ophthalmic vein arises from the tributaries in the inferior lateral part of orbit. The inferior ophthalmic vein may empty directly into the cavernous sinus, but more commonly joins the superior ophthalmic vein to form a common stem that drains into the cavernous sinus. Moving ahead, muscular relationships. So here's the orbital muscle. Here's the anterior aspect showing the orbital muscle, orbicularis oculi, orbital part, orbicularis oculi, medial part, and there's a lacrimal which lies behind the lacrimal fossa and attaches it to lacrimal bone. So here is the further dissection. Orbicularis muscle removed, exposing the upper and lower tarsi. Basically, these tarsi are plate of dense fibrous tissue situated deep to the palpebral part of orbicularis oculi muscle to give the shape of upper and lower eyelid. As you can see here, upper tarsal plate and lower tarsal plate. Here is the levator muscle. Here is the middle canthal ligament and lateral canthal ligament. Moving on to the last muscles attachment. So here is the basically eye globe. The eye globe and the optic nerve is surrounded by 4 rectus, levator, and orbicularis ocular muscles. So here is the superior rectus. Here is the lateral rectus. Here is the inferior rectus, and here is the medial rectus. Here you can see the inferior oblique muscle. Here you can see the superior oblique muscle, and here is the levator muscle as shown. Done, sir.
Thank you, Dr. Zohaib, for your presentation. As I said, this presentation was in 2 parts. There was a presentation on orbit last week as well. Now I will request Dr. Hasan Syed to please give his expert opinion and maybe share a case if he has one. Dr. Syed.
Sure, absolutely. First of all, that was a great presentation reviewing the anatomy. I think the anatomy can be quite complicated with the orbit because of all the structures that are there. And, especially as neurosurgeons, we don't necessarily always focus on that area. But I'm happy to share a couple slides if there's time. Is there time, maybe 5 minutes to share some slides?
Yeah, there is.
Actually, okay, so let me just early. Are you able to see that?
Yes, we are.
Perfect. Okay, so this is actually a couple of slides. I don't want to take more than 5 to 7 minutes, maybe just to go over a clinical perspective on the orbit. These are slides that I actually showed in Karachi as part of the skull base and spine course back in May. So I thought I would just show some slides to the trainees as well. But as neurosurgeons, we really focus on the orbital apex. And as was described, this is a space between the posterior ethmoidal foramen and the optic canal. And we really look at it from, a cone or a pyramid perspective, and the posterior most end of the pyramid essentially shapes the orbit. There's 4 bones that converge at the craniofacial junction. This area essentially contains structures passing through the optic canal and the superior orbital fissure, like you can see in the image. And it's important also to note, I'll bring up this image of the tendinous ring of Zinn. This is oftentimes, examined in the written and oral boards as well. So it's important to know the anatomy and the cranial nerves and the various branches that pass through this, as well as the ophthalmic artery, just to bring that up. When we think about the orbital apex, as I talked about, the medial wall corresponds to the lateral wall of the nasal cavity. That includes the ethmoid and sphenoidal air cells. And so I'll go through different surgical approaches, but one of the things that I had talked about was an endoscopic endonasal approach to this area, particularly the orbital apex, where we see pathology as neurosurgeons. And really the main steps to get to this location correspond to medializing the middle and superior turbinates, exposing and resecting the unsnit process, then approaching the bulla ethmoidalis and ostium of the maxilla, as you can see in the image. And then after resecting these ethmoidal cells, approaching the lamina propria and the lateral wall of the which is essentially the lateral wall of the area in question. So looking at the pathology, orbital tumors are relatively uncommon, 3 to 5 per 1 million per year. There's different clinical presentations depending on the location, and we think of intracanicular lesions that lead to early visual loss and papilledema. We think of intraconal lesions that also lead to early vision loss but late onset proptosis, and then extraconal lesions that lead to late visual loss and early proptosis. the specific to orbital anatomy and orbital tumors, this is just a table that describes the pathology. Oftentimes in adults, you see hemangiomas, schwannomas, gliomas, and meningiomas. In the pediatric population, that pathology sort of differs. And then, of course, there's malignant pathology as well. So this is the surgical approaches to the orbit, sort of this so-called round-the-clock algorithm. You know, we know that obviously the approaches to this include a large frontotemporal craniotomy, supraorbital approaches. You think of endoscopic endonasal approaches, especially from the inferior and medial portions of the orbit, additions of lateral orbitotomies to look laterally. So I really reference you to this article in 2015 to kind of go through sort of those surgical approaches. And I just wanted to end on this article that was published last year in the Journal of Neurosurgery, kind of putting things together and looking at the use of endoscopic transorbital and endonasal approaches to approach orbital tumors in a 360-degree manner. And certainly there's some morbidity associated with the endoscopic approaches, but certainly you know, they're less invasive compared to other approaches. But that's sort of you know, a perspective that I wanted to share as well. And again, thank you so much for that great presentation in terms of the anatomy.
Thank you, Dr. Syed. If there's any question, this is the time you guys can use the chat box to ask question. If there's no question, then we'll conclude the session. So I don't think there are any question. Dr. Syed, it was a pleasure to have you, sir.
Thank you very much.
We'll keep bugging you in the future as well for future sessions.
Sure. Yeah, happy to help.
We'll see you all next week with another topic. Thank you guys for joining. Take care.